Okay, this is an HSG, and this is a really abnormal HSG. And again, I get back to the point of telling you, make sure that the hysterosalpingogram is performed somewhere, preferentially within the first 7 to 10 days of the menstrual cycle. If you do it too soon and the patient is still bleeding, you don't want to propel endometrial bits of glands retrograde and incite endometriosis within the pelvic cavity. On the other hand, you want to make sure that you do the study before ovulation, before the patient is pregnant. And they lie. You love your patients, but they lie, and you say, when was your last menstrual period? And they make up a day because they're really trying to get the study done or whatever. And you say, well, did you have sex? And they go, well, no, I never have sex, but I've been trying to get pregnant for 2 years. You get these kinds of histories, but don't put yourself medical legally on the line. Just if there's any risk at all, you say no, because, well, there's this differential, but it's not any of these things. This was an intrauterine pregnancy. Okay, now, this wasn't from our institution, and I don't know where it's from, but I mean which hospital, but I will tell you from. This is an old case from the ACR teaching file, okay, when it was all on plain film, and I pilfered it and photographed it and made a slide out of it. So somewhere in this world, somebody did this. Now, it was that bad? Yeah, that was bad. Did the pregnancy, was it normal? Well, I don't know. But you do an HSG on someone who's pregnant, and that kid, 20 years later, doesn't win the Nobel Prize. Someone's going to come knocking on your door, named lawyer, and say, hey, I need to talk to you. So now you're warned. Okay, next case. This one is an Aunt Minnie, no real diagnosis. We have contrast via retrograde study and look at this deviation of that ureter, and that, of course, is the circumcaval ureter. We more commonly diagnose that on CT now, of course. I can never remember this. I've been giving this talk for a while, so I'm just going to tell you to read this. If you remember it, more power to you, and this is great. But I always get the infrarenal and the supracardinal mixed up. But, basically what's in green is what you need to know. In normal, the ureter, IVC is posterior to the ureter, and the abnormal, it's anterior. I think anyone would forgive you if you couldn't remember that. Even though I wrote a paper on it, I still can't remember it. Okay, so there's these other associations, horseshoe kidney turners and double vena cava. There you go. Now, what's on the differential? Remember, the normal oblique impression usually occurs at L5 or S1, and that's from the crossing iliac vessels. Okay, adenopathy or retroperitoneal fibrosis will also cause deviation of the ureter. I have a nice case of that I didn't throw in here, but it's adenopathy, and but that was the olden days. It was a great way to make the diagnosis. All these patients go to CT anyway. All right, here's an MRI, gadolinium enhanced, and what we see is the multilocular cystic renal mass. The septa are, in fact, enhancing, and you're wondering why the heck is she emphasizing that point, and I'll tell you in a minute. It's a multilocular cystic nephroma. Remember, these cysts are non-communicating, and they often protrude into the renal pelvis. Dr. Alan Davidson used to think that was a differentiating point between multilocular cystic nephroma and renal cell carcinoma. He probably still does. It just turns out it's not always the case, just so you know. There's 2 peaks. Remember that these lesions can have microscopic foci of Wilms or sarcoma, and so they are usually removed. What's a differential diagnosis? Remember, cystic Wilms. 5% of renal cell carcinomas, 5 to 7, are cystic. And multicystic dysplastic kidney. Now, multicystic dysplastic kidney has septations, but they do not enhance. It's usually that portion of the kidney is usually non-functioning. So if you see enhancement within the septations, then you have to start thinking of multilocular cystic nephroma. Okay, another case, CT, and you're looking at this and you're saying, there's peripheral wedge-shaped zones of decreased enhancement. Not only that, I see a bunch here, and there's one on the other side. So something that can affect the kidneys bilaterally. These are renal infarcts. Peripherally based wedge-shaped areas of decreased attenuation after contrast. The causes are multifactorial. Don't forget the arteridities. But what's on the differential? Acute focal bacterial nephritis. When you get heterogeneous enhancement on CT, you have to put this in the differential, as well as infiltrating neoplasm. So sometimes these patients just have to be brought for follow-up. Sometimes it's clear. The requisition comes UTI, rule out pyelonephritis. You go, oh, okay, I like that. But sometimes it comes with rule out. You know how those requisitions come? You say rule out, and you have to kind of make it up. So, look. All right. This is an odd case. You're sitting there going, I can't deal with this after dinner. Okay. Strange left ureter. You probably have to be a little bit more eloquent, in Louisville, but not a whole lot because they've seen it all. The first part of the retrograde, you can see that there's a collecting system that's filling, but there's not enough calyces here. Remember, the average number of calyces in the kidneys bilaterally is somewhere around 13 or 14. If you start counting them and you only get 6 or 7, you know that the chances are really good that you're dealing with a duplicated kidney, duplicated collecting system. So you also see the nephrostomy tube in here. And the nephrostomy tube is in this lower pole moiety of a horseshoe kidney. Now, how do we figure out it was a horseshoe kidney? Well, one of the other things is the way this angles towards the midline. If you recall how normal kidneys are oriented, the renal pelvis does not extend this far over the midline, and it suggests that there is, in fact, an underlying anomaly. The horseshoe kidney, remember, cannot ascend higher than about the level of L3 or so, which is the level of the IMA. That's usually where the isthmus has to stop, of course. And there can be multiple arteries, double ureters, and it's associated with the most important complication, which is Wilms tumor, 8 times more common. What would be on your differential? Cross-fused ectopia. Maybe there's 2 kidneys, they're fused together, and you've got 2 collecting systems, one upper and one lower. Or the disc, cake, or lump kidney. That's very rare. I've only seen that once or twice. Okay, next case. An IVU was performed. The right kidney never opacified. The left kidney had this odd collecting system, which was a little splayed. That turned out to be due to multiple cysts. But what happened was when you know the diagnosis or the differential diagnosis of an unopacified kidney, renal artery embolus. Remember in the beginning, you might get a cortical rim of contrast due to capsular collaterals, and then the kidney shrinks down after 2 to 3 weeks. What else can look like that? Acute obstruction, which is the most common. Okay, it's not renal artery embolus. Unopacified kidney, renal obstruction. Renal vein thrombosis. Remember, the kidney may not be there. And then the others, less common. Okay, renal mass on the right, bilateral renal cysts. We'll ignore the renal cysts. They're too insignificant to discuss tonight. But I wanted to show you a case of cystic renal cell well, actually, that wasn't cystic. That was solid renal cell carcinoma. Remember that they can be familial and bilateral. Von Hippel-Lindau, in particular, multiple renal cell carcinomas. Patients who present with the classic triad are vanishingly few and far between. And a small percentage do have METs at the time of diagnosis. The types, you can just read that. No one uses IVU anymore really to look for a, quote, tumefaction. Ultrasound picks it up once in a while, but CT is what we use, and MR can be a problem-solving modality. I wanted to mention the fact that in the literature through the years, certainly the last 5 to 7 years or so, there's been enough articles emphasizing the need to image early and late. In other words, if you just look at the nephrogram phase, occasionally medullary lesions are missed or are difficult to see because of lack of opacification. When you image them later, you can actually pick up the subtle lesion a little bit more readily. The Robson staging is shown here. If you've memorized the TNM, that's great. I always forget the TNM, so I use the Robson. I don't think anyone, the urologists tend to use the Robson just a little bit more than TNM, but that may be changing. The differential diagnosis, everyone needs to have a differential diagnosis for renal cell carcinoma. You are going to get shown some malignancy. You're going to get shown a renal cell, you're going to get shown or a transitional cell, or a lymphoma, or an oncocytoma, some kind of renal mass, and have a differential in mind. Next case, again, some renal cysts on the left, but what I want you to notice is this hypodense adrenal mass. Hypodense adrenal mass brings to mind adenoma, benign adrenal cortical adenoma. Remember that the cutoff that we tend to use generally is less than 18 Hounsfield units. Israel published a study about a year and a half ago using a cutoff of 10, but then of course he used MRI to figure it out. Remember that if you operate in a place where you look for delayed washout on the 15-minute scan, you can also make the diagnosis because these wash out more than carcinomas. We do too many patients. We don't wait for the 15 minutes. So we do the non-contrast and then we do contrast, but any questions and the patients go to MRI. And this is what we look for on MRI. You compare the in-phase and the out-of-phase T1 gradient echo images. You can calculate a signal intensity index, which is the in-phase minus the out-of-phase divided by the in-phase, and if it's greater than 16%, it's an adenoma. Very often you can eyeball it. And you look for signal intensity compared with the spleen. Do not compare signal intensity of the adrenal gland with the liver because the liver can be involved with either fatty replacement, hemochromatosis. It's just not a reliable organ. The spleen is what we use. Now remember, false negatives, some adenomas are lipid poor. And false positives are that some metastases, renal cell, liposarcs, hepatoma will contain fat. Unilateral adrenal mass have some kind of a differential. You're not going to have to get past about 3 for anything. So don't freak out. They just want to make sure you're not dangerous. I mean, you're not going to go out there and kill someone. They probably have to worry, I understand. But, you've all been fairly well trained and, you're going to do fine. Okay, this is an interesting case. The patient had an IVP, IVU, followed by a retrograde pyelogram because the right kidney never opacified. And the patient, this was at the VA, and so they just did the patient right away. That would never happen now. You'd have to be rescheduled and come back, blah, blah, blah. But at any rate, so you've got this big kidney on this side with sort of a distorted collecting system. You've got a defect in the ureter here, and then this abrupt terminus, with no normal pelvis or calyces. And what this is a patient, what I didn't tell you, and which no one will ever put in the history, is that the patient was on hemodialysis, and this was a renal cell carcinoma growing out of the right kidney into the right ureter. Because the patient was on hemodialysis, the patient not only had the cysts, which are associated with patients on hemodialysis, but you will recall, or you will learn tonight, that there is an increased incidence of renal cell carcinoma in patients on hemodialysis. So you can put all these findings together and make the diagnosis. It's a rather painful way to go through this. These patients do not always come to CT because they are in renal failure, but then they're going to get dialyzed. So some do and some don't. The other way you can evaluate this, of course, is with MR. Differential would be bilateral renal cell CA because there's so much distortion of the collecting system on the left, and then your differential for a filling defect in the right ureter. Now, here's something you might get asked. Here's an IVU, here's a 1-minute film and a 15-minute film. And there's just some way that they want you to know what to do in case of a contrast reaction. Recall that you see an increasingly dense nephrogram on an IVU. Since we don't do those a whole lot anymore, what will really happen is that, code blue will go off in the hospital and you have to run to the CT scanner. And make sure that, or if you're, in an outpatient clinic someplace or freestanding office, you would know what to do. But just know the types of, generic types of contrast reactions and how you would generally treat them. I mean, you don't have to know the exact doses. You certainly don't have to know pediatric doses, but, know about Benadryl, fluids, epinephrine, and atropine at the very least. Okay, there is a differential diagnosis for this, and sometimes you will see this on CT, and it includes ATN or acute tubular blockage from just about anything. Patients who, particularly leukemics who are treated, most of the time we don't see urate nephropathy anymore. I saw a case just last week. Okay, large extrinsic filling. Do you see this renal pelvis here? Notice how there's something there. And then we also notice that there's a bullet, which is intriguing. A catheter is in place. So we've got something that's impressing on the collecting system, whether it's a cystic renal mass, something extrinsic to the kidney. It could even be lymphadenopathy. But then we notice the bullet, and we say, aha, one of his friends did it. As one of their friends always ends up doing things like that. What we have is a large renal arteriovenous malformation that went undiagnosed for some time after this patient sustained the gunshot wound. 70% are acquired. That does not refer to gunshot wounds. 100% are acquired. However, 75% of renal AVMs are acquired, 25% congenital. And remember that they can also form from neoplasms. What you see on CT or angio, of course, is concomitant filling during the venous and arterial phases. Okay, this is kind of an Aunt Minnie. We're looking at the kidneys. We see multiple bilateral renal medullary calculi, and we immediately recognize that as, well, we don't immediately recognize it as renal tubular acidosis, but what I wanted you to go through is the differential for nephrocalcinosis. In this particular case, it's hard to tell that this is a child. The apophyses here are incompletely fused, but that's hard to see from the back of the room. So you're forgiven, but that is the most common cause in children. Stadium ditch, that's one. You know, you need, again, probably 3 or 4 causes of nephrocalcinosis. You probably would get shown an ultrasound. You might get shown a CT. If you got the CT, remember to ask whether or not contrast has been given or not, because you might not be entirely sure if the calcifications are faint and they're just in the medulla. Another case of a KUB where you look at the kidneys, you look at the bones, you see bilaterally enlarged kidneys. These are very big kidneys. And this is really a nasty slide to show you because it just doesn't even project very well, but there are black bands down here, which are lucencies in the metaphyses. In a child with large kidneys and lucent metaphyses, leukemia is the diagnosis. Remember, leukemia diffusely infiltrates the kidneys, and renal involvement is in more than half of patients. What else causes bilateral enlarged kidneys? A lot of things. You don't have to know all of these. If you can name 2 or 3. The most common that we see is probably acute obstruction, renal vein thrombosis. I would say those are probably the 2 most common. Bilateral hydro. Okay, retrograde study. What do we have here? An irregular stricture in the proximal left ureter. Now, anytime you see a stricture anywhere in the GU tract, the next word out of your mouth should be TB. Okay? You're going to say, tumor, radiation, whatever. Say TB. TB is on the rise again in the United States. The GU tract is a favorite place for TB after the lungs, but its classic manifestation is strictures. And TB starts in the kidney and works its way down, as opposed to schistosomiasis, for example, which also contributes to strictures in the GU tract, but starts in the bladder and works its way up. So you would think of schistosomiasis, and you'd think of all of the rest of these, including radiation therapy. Here's a case of schistosomiasis. You can see the bladder calcification, which is classic. You can see the irregularities in the ureters. One resident came back one year and said that, again, a nasty examiner, and I'm sure this wouldn't happen to you, showed a case of schistosomiasis with calcification in the bladder, and then there was an area where the calcification was interrupted. It was interrupted because these patients have an increased incidence of squamous cell carcinoma, and that's where the tumor was, where the calcification was not. Okay, just, we're stretching a little bit here. The idea is to show you things that you're not seeing in everyday practice and you're not necessarily seeing at your home institutions, but that you will have seen sometime in your life, and hopefully better here than in Louisville. All right, now we've got a right-sided renal mass, but the key thing is that we've got adenopathy, and we have a mass in adenopathy, lymphoma. Remember, lymphoma can show up in the kidneys with generalized enlargement, a focal mass, adenopathy. Okay, differential, again, renal mass, that differential. Okay, another IVP, we have no filling. We have just a funny looking lower pole to this kidney. How many calyces do we have? Certainly not enough. So, is there a mass here? What's going on? Why is that not opacifying? Renal tumor, abscess, could it be a segmental multicystic dysplastic kidney, which approximately 7% of people have? So that means probably 4 of you in this room right now. Ha, you thought you were perfect. You are, but anyway, UPJ obstruction, lower pole moiety of a duplex kidney. Now, remember these are congenital and due to either functional obstructions or stenosis, a valve, a kink. They can be acquired and are often acquired due to scarring or reflux. Remember, there could be transitional cell or squamous cell causing the obstruction. Remember that the lower segment of a duplex kidney has the UPJ more often than the upper. Okay, let's move on to an MRI. Bilobed cystic mass. This is a T2 weighted image. This is a T1 weighted image after gadolinium. And you're trying to figure out the anatomy. And you're going, okay, this is sort of like rectum or anus. You're right, it is. Yeah. Then this is the urethra anteriorly. Now, in between is where the vagina sits. So you're not sure what this is. And before you say it's a septated vagina, those are pretty rare. So don't go out on a limb. Say, well, do you have another projection? I mean, that's the beauty of MRI. You've got coronals and you've got sagittals, so ask if you can see something else. So you get shown the sagittal, and sure enough, here's the uterus, here's the bladder, here's this cystic mass, which has a little bit of a fluid level. Is it coming out of the urethra, or is it coming out of the vagina? Well, I can actually see the vagina here coursing, well, that's the answer, but coursing posterior to this thing. Okay, you still can't be 100% sure it's coming out of the vaginal wall, but, common things do occur commonly, and this is the urethral diverticulum. Remember, they're acquired, and, they present with dysuria, post-void dribbling, dyspareunia, and rupture of dilated and infected periurethral glands is thought to be the etiology. Complications: recurrent infection, stones in 1 to 10%, and a small incidence of adenocarcinoma. Very rare, though. Now, what else can look like that? If it were coming out of the anterior vagina, you'd have to consider a Gartner's duct cyst, a paramesonephric or Müllerian remnant cyst, or an epithelial inclusion cyst. Ectopic ureteroceles, you'll recall, can insert into the vagina in women. Endometriosis, you want to make sure this is not a hemorrhagic lesion that's implanted in the vagina. And urethral tumors, which are usually squamous cell, not too common. I happened to see one today that was 5 by 6 centimeters, and we had the same problem that you would have with this case. Is it coming out of the vagina? Is it coming out of the urethra? I had to put both in my differential. It's coming out of the urethra. Now, here's another case. This looks almost like the other one. This is a Gartner's duct cyst. On the sagittal image, here's the urethra, which is pristinely coursing in a craniocaudal direction with nothing coming out of it. This thing looks more like it's centered in the anterolateral wall of the upper vagina, which it is. That's a Gartner's duct cyst. Here's another case. Periurethral diverticulum, yeah, maybe. I had a good day that day. I must have had some coffee, but I was looking at this thing saying, this is my T2 weighted image, and it's high signal, but it's not that high. And I said, let's go ahead and give GAD, because you don't always have to give GAD with periurethral diverticulate, although it's nice because you can sometimes see the delayed filling. And I saw that there was some enhancement, and I went, whoa, I have to start thinking about other things. And because I had seen one other case in my life of metastatic melanoma, I did put that in my differential, and that's what that is. But you can get metastases, and don't forget to put metastases on the differential. Okay, don't worry, you're not going to get one of these for about 10 years, all right? But now you've seen your one. All right, this is something more straightforward, okay? Solid renal mass and the buzzwords, central stellate scar, oncocytoma, home run. You all know about oncocytomas. You know this is what they look like on angio. You know that we don't do angio anymore for those, but that's what they look like. Okay. Next case, we have a dilated renal pelvis, and we have stuff. We have junk in the collecting system, but we don't know if it's really junk. Is it debris, fluid, is it tumor? Well, these have to be on your differential, transitional cell first and foremost. You always want to mention the thing that if you don't mention it, the patient dies. It's a good rule of thumb. Don't forget that one. Transitional cell carcinoma of the renal pelvis. And we talked a little bit about transitional cell already. This is another case. I had this one about 2 weeks ago. A patient presented with hematuria. This is subtle. This is subtle, guys, but this is the state of the art. You know, we're doing helical CT now in place of IVU, and we're using our 64 slice with narrow collimation, you know, to do stacked reformations. We're looking at the ureter in toto, and anything that is subtle like this will stand out, but you have to have your eyes open for it. And of course we did, you know, early and delayed images, but this was in fact another transitional cell. Next case, okay, we have 2 kidneys. That's a good start. And someone went ahead and measured them. The one on the left is 12 and the one on the right is 14.5. The left kidney is bigger than the right. How much bigger? 2.5 centimeters. Is that okay? No, that is not okay. That is too much. The left kidney should not really be more than 2 centimeters larger than the right kidney, although the left kidney can be larger than the right kidney normally. Unilateral enlarged kidney, obstruction is the most common thing. But don't forget, maybe it's compensatory hypertrophy, been around a long time, and then you can go through these other weird things, or not so weird. But what this turned out to be is, in fact, a duplex kidney. I wanted to mention the Weigert-Meyer rule. Remember, in 85%, the upper pole ureter opens below and medial to the lower pole ureter. And in women, that ureter can open up into the vagina, and it may be associated with a ureterocele. In males, the ureter opens in the upper third of the prostatic urethra, so men will not be incontinent if they have this problem. Okay, duplex kidneys with double ureters. The upper pole obstructs and is more often dysplastic. The lower pole refluxes. Now, if perchance there is a UPJ obstruction, which is congenital, it more often involves the lower pole. That's a little complicated. If you just remember this and this, you're fine. You're fine. We don't want to overload. Now, here's an interesting case we don't see every day, but there isn't a differential. You're looking at a CT scan and there's just lots of fluid all over the place, and you see something that looks like a bag that's been burst and it's enhancing, and that's exactly what that is. It's a UPJ obstruction rupture. Usually after a blunt injury, it could be spontaneous. This was the retrograde study, and contrast was just spilling out into the peritoneal cavity. That's what it looks like if you've never seen it. Next case, scout film, HSG. Now, we don't usually take a scout film, but you're supposed to kind of look where that catheter is before you put the contrast in. I mean, you don't want to have perforated the uterus. You don't want to see the catheter up over the liver, so you kind of fluoro and make sure where it is. And because you're smart, you notice that the catheter is deviated a little bit to one side. And you also noticed that let's just say that it's deviated. Okay, you go ahead and you give the contrast, and you're seeing that it is, in fact, deviated to one side. So why? Then you look closely back at your scout, and you notice this thin peripheral rim of calcification, And when you see calcification and it's associated with the uterus, it's an intramural leiomyoma. This didn't have to be intramural, but you should have suspected uterine myomas. Remember how common they are. Remember that they're smooth muscle tumors, benign, submucosal, tends to be the ones that present with a lot of problems regarding infertility and recurrent abortion and hypermenorrhea. But location, location, location. Looks a little bit like real estate, you know. If they're subserosal, they can present with torsion and abdominal or pelvic pain. And intramural, usually infertility. They can undergo different types of degeneration and have varying signal intensities, but usually intermediate to low on T1 unless they're hemorrhagic, and high, well, not really high. High if they're degenerating on T2, but otherwise heterogeneous. 0.5% of these will be leiomyosarcomas or degenerate into leiomyosarcomas, and MR is incapable of differentiating leiomyoma from leiomyosarcoma, although some of the things that I tend to use in my practice are looking at growth rate and just sort of how ugly they are. If you see something that's big and has a nasty interior, then you can suspect a leiomyosarcoma. Right now, we, like a lot of people, are doing uterine artery embolization for these, and MR is the way we follow them up. Another HSG, and you see a small diverticulum projecting from the uterine cavity. This is a common diagnosis, the lollipop diverticulum that you see with adenomyosis. Remember, adenomyosis is the glands of the zona basalis, which are no longer found in the endometrium, but they are found within the inner myometrium. The best thing to use to make this diagnosis is MRI, and the criteria are a junctional zone greater than 12 millimeters. You'll see high signal intensity foci in the T1 and T2 weighted images representing hemorrhage, or you will see high signal intensity foci on the T2 weighted images alone, representing the ectopic glands themselves. Here's an example of diffuse adenomyosis with the small punctate glands, and this is a more focal adenomyoma. You may say, why does it matter? Well, it matters because until just very recently, and studies are still being conducted using uterine artery embolization to see whether or not adenomyosis will respond as well as uterine fibroids do. Very often, patients would go to myomectomy to have their fibroids removed, but the treatment for adenomyosis is hysterectomy. You don't want to make this mistake. I made this mistake when I was junior faculty. I called this a fibroid. And they took the patient to the OR. I got an angry call from the gynecologist who said, "Is this Dr. Stevens?" You know, I started to look around and go, "No, she's not here. She went out to lunch." And I said, "Yeah." And he said, "Well, you said that that patient had fibroids." And I said, "Well, I thought she did." And he said, "Well, we go ahead and went and consented her for a myomectomy, but what she has is adenomyosis, and we did not consent her for hysterectomy." I said, "Oh." So it was not a good day. But I don't want that to happen to you, and just remember that there is, in fact, a focal form of adenomyosis. I did not get sued, and I'm very happy, and I go to church a lot now. Okay, so next case, we see a lot of staghorn calculi, which are usually struvite, magnesium ammonium phosphate, although remember, staghorn is just the descriptor. Struvite is the chemical composition, but they can be calcium oxalate, they could be calcium wetolite, calcium wewelite. There's all these different kinds of stones. But at any rate, we've got some struvite stones here. And then we've got a CT. And what do we see? Not only these calculi, but we see these low density foci in the right kidney and all this perinephric stranding. And we know it's xanthogranulomatous pyelonephritis. Remember that these kidneys on CT may not enhance. They may not have renal function. That's the only thing you need to know. And the treatment, by and large, is nephrectomy. Differential. How do you differentiate that from a garden variety abscess? You don't know that those are just xanthoma cells in the middle of that kidney. They could be abscesses. You've taken it as far as you could. Okay, HSG, and you say, it's a Müllerian duct anomaly. But which one? That's the tough part. Remember that the Müllerian duct anomaly that has the greatest fetal wastage is the septate uterus, because the relatively avascular septum means that if the fetus implants on that, it will outstrip its blood supply. So differentiating a bicornuate from a septate uterus is of paramount importance. The difference, in essence, is that the bicornuate uterus has a fundal concavity, whereas that of the septate uterus is flat or convex superiorly. An example on MR, which is the best means to diagnose it, because as you're well aware, HSG only shows you the internal aspect of the uterus, you can see this fundal concavity. And the Müllerian duct anomaly classification, I just included it so you can look at that in the last 10 seconds before you throw up when you walk into your exam, and you'll go, okay, I kind of know that. Next. This, I'm lying, this is not really a hyperdense cyst, but I put it here because it reminds me to talk about hyperdense cysts, and I have another example later on, but just remember when you're evaluating these, there are certain criteria that have to be met before you call something a hyperdense cyst. And the reason it's paramount to fulfill all these criteria is that, except for one case reported in the literature in like 1992 or 1994, hyperdense cysts are usually benign. Again, usually not renal cell carcinoma. If they are less than 3 centimeters and they have Hounsfield units in this range, and at least a quarter of the circumference projects outside the kidney, it's a simple hyperdense cyst and you can ignore it. The diagnosis is the following. Again, Hartman in 1992 showed one case that was not. And he examined me on the board, so I had to put it in because he scared the heck out of me, and I didn't think, he's a very nice man, but that was a tough case. Here's an example of autosomal dominant polycystic kidney disease with a hyperdense cyst. When they say you've got a renal mass, particularly a cystic renal mass, and they ask you how to work it up, note that Bosniak in January of 1986 came out with a classification which included uncomplicated lesion cysts, minimally complicated, some findings of malignancy which require resection, usually, and 4 which definitely do. Bosniak recently came up with 2F, which is these criteria. Things look benign, but they're just a little bit touchy. The septi are thickened, or there's a few more calcifications. Benign cysts fulfill these criteria on CT, and these on MRI. Examples of the category 1 benign cyst, the hyperdense cyst, which is benign by and large. The category 3, this is a multilocular cystic nephroma, and of course a cystic renal cell carcinoma, which would come out. With little more ado, I require just 30 seconds to give you some challenging bonus cases because I know how smart you all are. We are looking at a retrograde study filling up this lovely heart-shaped bladder, which turns out to be a duplicated bladder. I've never seen one, but it makes a really good slide, and there are 3 types, which you won't need to know, but I do point out the associated anomalies, which really boggle the mind. Really boggle the mind. Okay, and not skip that differential. And then we move on to another common case, which, believe it or not, is a prolapsed ectopic ureterocele presenting as an interlabial mass.
But before we start, I do want to just have 1 minute on the oral board exam in cardiac imaging. This has been on for about, this is the 3rd year. So there are cardiac cases in 4 different sections. There's a section called cardiopulmonary, which has 4 cardiac cases and about 6 to 8 pulmonary cases. The rest of them will be pulmonary. And for the pulmonary score, only those 6 to 8 cases will count. Okay, so interventional, 8 to 10 cases in interventional, and 2 cardiac. Only the 8 to 10 cases will count for the interventional score. For nuclear medicine, there will be 1 cardiac and 8 to 10 general nukes, and only the general cases will count. pediatrics, 1 cardiac, and 8 to 10 general pediatric cases. Only the general pediatric cases will count for pediatrics. All of the cardiac cases, though, are taken out of those exams and scored separately together. The pediatrics cardiac case, by the way, can be congenital, usually is, but may be an acquired disease in a child. Okay, so we have these cases, that equals 8 cardiac cases, and that will get a separate score. That's called the virtual cardiac exam. And if you condition that, you can retake it the following November, and you take a real cardiac exam, so you'll get all cardiac cases. Okay, so let's go on. I'm going to show you a few cases from Dr. Higgins' syllabus because he, for time purposes, he cut out a few of the cases that I do want to show you. So they're not unknowns, but this is essentially a double aortic arch. You can see the right arch is higher and larger than the left arch. That is typical. So the right arch in a double arch is higher and larger. And this is a vascular ring, meaning that there's a ring around the trachea and esophagus. And what is the problem with the vascular ring? It can cause airway compression and airway symptoms such as dyspnea and wheezing. And this is how it looks on the axial view. There's the higher, larger right arch and the lower, smaller left arch. Double aortic arch, vascular ring, tracheal compression. This is a different patient. What does this patient have on this plain film? A right aortic arch. Important to remember this, not too difficult a diagnosis on the plain film, but remember there are 2 major categories of right arch. Mirror image right aortic arch, which is strongly associated with cyanotic congenital heart disease, especially tetralogy of Fallot and truncus arteriosus. 98% of patients with a mirror image right arch have cyanotic heart disease. And then there's the non-mirror image arch, which is a vascular ring. Non-mirror image right arch. This is a right aortic arch, non-mirror image with an aberrant left subclavian artery. It's retroesophageal, and it's a vascular ring with compression of that trachea. Now, a left arch with an aberrant right subclavian artery is not a vascular ring. Remember that. Left arch with aberrant right is not a vascular ring. This is a vascular ring, right arch with aberrant left, as is the double arch. Pulmonary sling is a rare type of vascular ring in which the left pulmonary artery takes off from the right PA. So the left PA arises from the right pulmonary artery. There's no bifurcation. In other words, look here, there's no bifurcation. This comes here, swings around, and slings that trachea, okay? And that is also a vascular ring. That's pretty rare. Now, I do want to point out, that's all for vascular rings. Let's now talk about partial anomalous pulmonary venous connection versus left-sided superior vena cava. This is something that you will need to know, and these cases pop up all the time on the boards. Okay, so with a partial anomalous pulmonary venous connection, Dr. Higgins showed you a number of cases this morning, but with a left upper lobe connection, there is a vertical vein. So this is the left upper lobe pulmonary vein, and there's a vertical vein going up and draining into the left brachiocephalic vein. Okay, so that's what it looks like here. If you see a round or oval structure on the left side of the aortic arch, it's one of 2 things. Round or oval vessel on the left side of the aortic arch, it's one of 2 things. Partial anomalous pulmonary venous connection, it's the vertical vein for the left upper lobe pulmonary artery, versus a persistent left superior vena cava. It's one of those 2 things. How do you differentiate? It's important to differentiate. How do you do that? Well, on these axial images, what you're looking for is, does the vessel branch at the hilum? In other words, are there branches coming into this vessel at the hilum, in which case it's an anomalous pulmonary vein? But if there's no branching in the hilum, if it continues inferiorly into the coronary sinus, that means it's draining into the coronary sinus, and that is the persistent left SVC. So this is branching in the hilum. You don't see that vessel again at the level of the hilum. Instead, you see these branches, and that's depicted here. So that's branching, and what's the direction of blood flow here? It's superior into the brachiocephalic vein. How about this case? So there's the round or oval structure to the left side of the aortic arch. It's a vessel. So we know it's a vessel. It's either persistent left SVC or partial anomalous pulmonary venous connection of the left upper lobe with a vertical vein. And let's follow it. This is the hilum. Is it branching? No, I see no branches coming into it. And we can follow it inferiorly. It goes into the coronary sinus. Persistent left SVC drains into the coronary sinus. Left upper lobe, partial anomalous pulmonary venous connection originates at the hilum, goes superiorly into the brachiocephalic vein. Very easy. You should know how to differentiate it. It's a very easy case if you get it, especially if it's shown axially like that. Hopefully it will be. Okay, a couple of other things. This was the coronary artery anomaly that Dr. Higgins showed. This is an interarterial course going between the aorta and pulmonary outflow tract. This is bad. Some people refer to this as malignant. I usually don't like that term because malignant implies really, really bad. Okay. But anyway, so what's the risk? This can be compressed between those two big vessels, between the aorta and pulmonary artery. They compress that small artery, the coronary artery. So what's the problem? This can lead to ischemia. So the patient can have arrhythmia, chest pain, syncope, or sudden death. What does sudden death mean, by the way? It means that the patient suddenly dies, but they may or may not be revived. Actually, sudden death is equivalent to cardiac arrest. So people can have sudden death, a history of sudden death, and they're still alive. Okay, so this is bad. Any coronary passing between these two vessels is bad. How about this particular coronary artery anomaly? You see this anomaly passing posterior to the aorta. See, there it is, posterior to the aorta, and it's actually connecting there. That's the circumflex artery, which is anomalous. Now, is this bad? No, this is a normal variant. If it's posterior to the aorta, it's a normal variant. This is the so-called benign variant, retroaortic, not bad. Interarterial, between the aorta and pulmonary artery, bad. That's all you need to know. The interarterial course can lead to ischemia. Those patients need surgery. How do you treat it? Surgery, either reimplantation of the artery or CABG. Okay, you also will need to know coronary CT. It's not that important to know all the aspects of it, but at least you should be able to tell what are the major arteries and is there a stenosis or an anomaly. I showed you an example, a couple of examples of anomaly. This is a case without an anomaly, but what does it have? This patient has a stenosis. It's very easy. That's the most you would be shown on a coronary CTA. Okay, so you should know the stenosis. Where is it? Well, that's the angiogram. You're not going to be shown an angiogram. You could be shown a CT. There's a CT scan. There's a stenosis right there. That's the, which vessel is this, by the way? Left main bifurcates into the LAD, and circumflex, and that's right at the LAD where the first diagonal comes off. If you just know LAD, circumflex, left main, and right coronary artery, you will pass. You just have to look for that stenosis or look for an anomalous vessel. If you see a coronary artery image, look for stenosis, anomalous vessel, and know those four major vessels. Left main, LAD, circumflex, and right coronary artery comes off over here, although it's not seen on that image. Okay, and then the other image that I wanted to show you was this delayed enhancement. About 10 minutes after the gadolinium injection, maybe 10 to 15 minutes, we do the delayed enhancement imaging. You will get the history. This image was performed 10 minutes after gadolinium injection. If you get that history, you know that you're looking for delayed enhancement. What does that mean? Delayed enhancement means that myocardium is dead. Okay, it's infarcted. It's not viable. Okay, so white is bad. So it's delayed enhancement, infarcted. So what's the point? Why do we care whether it's infarcted or not? Because if tissue, myocardial tissue, is functioning poorly, perhaps the patient can improve with revascularization. So they may have surgery or angioplasty to help that patient's heart. But if the heart is dead, if the tissue is dead, my residents are laughing at me. They've never seen me so forceful and so passionate about anything. But I really care about this topic. Why would we Why would we care? Because if the tissue is dead, even if you bring lots of blood and oxygen to that tissue, it's not going to improve. So this is not going to improve. That's what you need to know. This is not viable, and even if you revascularize, it won't improve. So requires medical management. No surgery here. But if you only see black, if you see dark myocardium all over, then that patient can benefit from revascularization and should undergo angioplasty or surgery if appropriate. Okay, now this is in this syllabus from this evening. So what's going on here? Okay, so we see a non-contrast image of the aorta and then a post-contrast. Frequently on the boards, you may just get a non-con image, even of the aorta, because a lot of people do non-contrast images. You have to look for blood. Do you see mediastinal blood, as I showed you this morning? Do you see pericardial blood? Or do you see an intramural hematoma? You see this high-density rim? This can be either circumferential or eccentric thickening and high density of the aorta on a non-contrast image. This is intramural hematoma. Type B, descending aorta only. Type A is ascending aorta, but I don't see that here. So this is type B, this is medical management. The earlier case I showed you was type A, that is surgical management. So intramural hematoma, similar in many ways to a dissection. How about this? Plain film of a child, of an infant actually. Cyanotic. Okay, I don't want to be pummeled by Dr. Higgins. Okay, so cyanotic, by not giving you the history. Okay, so what do we see here? Well, first of all, there's decreased vascularity, which is quite readily apparent in this case. The heart is normal in size, and what else do we see? We see a right aortic arch. If you see a right aortic arch in a child with cyanosis, you know it's either tetralogy of Fallot or what? Truncus arteriosus. This particular individual has decreased vascularity, that's tetralogy of Fallot. Normal or decreased is tetralogy, increased with the right arch, increased vascularity is truncus arteriosus. How about this? The history for these cases will be arrhythmia or tachycardia. You don't even need to see the image on the boards. If you see that history, you know the diagnosis. Just make sure that you're actually looking at the image to make sure it's not something bizarre. But look at the image, look for this finding, look for fatty infiltration of the right ventricular myocardium, arrhythmia or tachycardia. I would say there's fatty infiltration of the right ventricular myocardium consistent with right ventricular dysplasia. And you will get that case in 5 seconds and move on, unless the examiner is really mean. Okay, so what's this? CT scan. What do we see? Right ventricle, right atrium, left atrium. There is an ASD, very easy case, atrial septal defect. What's that, by the way? That's the moderator band. It's a feature of the right ventricle. How about this? This is an aortic case, an MR image. So there's marked dilation of the ascending aorta. Is this coming all the way down from the root? Is this dilated down from the root, or is it just dilated above the root? It's dilated at the root. So what is the diagnosis? Annular aortic ectasia associated with Marfan syndrome or other connective tissue disorders. How about this? Okay, so we have an MRA. I'm going to rotate that for you. So there's the aortic arch. Look at these arch vessels. What do you think about them? So there's stenosis, multiple stenosis in those arch vessels. And this is a young patient. She was only about 35 years old. And in this particular entity, the stenoses are not right at the origins typically. They're a little bit away from the origins of the vessels. This is characteristic of Takayasu arteritis, in which a young patient has multiple stenoses. Most common locations are the arch vessels, although it could be in the aorta, sometimes in the abdominal aorta, sometimes in the pulmonary artery. But arch vessels are characteristic, and I think if you get it in the arch vessels, you should definitely know the diagnosis. Again, look at this. You can see the stenosis there. Does everyone see that? And some here in the subclavian artery. Okay, so they tend to get multiple stenoses in the arch vessels. Okay, so coronary artery image. This is normal anatomy. I'm showing you the axial image. There's the aorta, left main, LAD, and circumflex. That's very easy. You should definitely know those vessels. And you should be able to tell whether there's a stenosis. I see no stenosis here, but you should be able to tell whether there's a stenosis or anomaly. And the right coronary artery comes off on the right side, but it's not imaged here. Any abnormality here? Now, one of the things is, especially in the past, they used to, many of the cases that people are shown of coronaries tend to be these weird obliques that are reconstructed and no one can tell what's going on. But if you see a coronary artery, even if you can't tell the plane, it could be a coronal oblique, an axial oblique, you can't tell the plane, it doesn't look normal, but you see coronaries, look for the anomaly. If you see the anomaly, that's fine. If you don't see the anomaly, then look for a stenosis. What do we see here? That's the right coronary artery. That's the right coronary artery. And that is the left coronary artery passing between the aorta and pulmonary outflow tract. That's the interarterial course. This is an interarterial anomalous coronary artery. Next case, very easy. At least for me, since I know the answer. Okay, how about this? What is that? There's something going on in the left ventricle. And actually, interestingly, there is also in the right ventricle. These are filling defects. What could they be? They're thrombi. What's the most common mass in or adjacent to the heart? Thrombus. These are thrombi. Why would you get thrombi in the left ventricle and right ventricle? That's pretty unusual to get that. This patient had coagulation abnormality. Much more common to see thrombi either within a left ventricular aneurysm, that's due to the aneurysm, or perhaps in the left atrium, which is usually due to atrial fibrillation or mitral stenosis. What's this? I told you this is never used clinically nowadays. These images, most of the good images are about 10 to 15 years old, and the reason for that is that the jets are actually artifacts, and the current cine imaging with steady state free precession, SSFP cine imaging, is so good that it minimizes the artifacts, and we get beautiful images. This was when the images were not good, and that's why we could see these artifacts so well. But essentially, there is the aortic valve. What is that jet? That's a post-stenotic jet. It's distal to the valve, so it's a post-stenotic jet. This is a stenotic jet. What if the jet came back this way? It's proximal to the valve. Jet that way is regurgitation. So this is a stenosis since the jet's going that way. Next case. Status post-cabbage. This is actually a difficult case. In that the finding is difficult on the boards. Most of the findings are not that difficult. They're pretty easy. That's one of the reasons why they don't show acute PE in general on the boards, because you either see it or you don't. If you show a big central PE, everyone will get it. If you show a tiny PE in the periphery, you might miss it even if you're a good candidate. So they don't typically show that. But anyone see anything abnormal here on this post-operative chest radiograph? Look carefully at lines and tubes on ICU images because sometimes they are malpositioned. That's important to note in the chest section. What's this, by the way? That is a retained surgical sponge, and this was actually missed over several images by several attendings and several fellows, all in the chest section. Luckily, I was out of town that week. Okay. Next. Okay, so cyanotic child, what could this be? So decreased vascularity and cyanosis and a huge heart. If you just said one thing, I would pass you on the case and move on. Epstein anomaly, if you just say that, that is fine. If you give the differential, that's even better, but you don't have to remember the differential. You have a million things to remember. You probably, in practice, you may just see a few Epstein anomalies in your entire life without the actual history written down there in front of you. Otherwise, a de novo case is pretty unusual. This is one of the few that I've ever seen. So what's the differential diagnosis? Critical pulmonary stenosis and certain types of pulmonary atresia and tricuspid atresia. If you just say Epstein, you're perfectly fine. And on the boards, a lot of the images are not good quality. They're very old and they were scanned in. Okay, so you have to be thinking, how can I tell whether this is decreased or increased vascularity? If someone says cyanosis, that's really the only time you have to tell. And sometimes they don't tell you. Despite what Dr. Higgins says, sometimes they do not tell you whether the patient has cyanosis or not. And luckily he's not there. He doesn't go and examine. But essentially, how can you tell? Well, the best places to look are on the lateral view, posterior to the heart, and in the retrosternal space. And this is completely filled here. But posterior to the heart, I don't see any vessels. The other thing is, if you say, this is normal to decrease vascularity, you're probably going to be right. And if you're not, then I would say, how do you tell? And that's a hint that maybe you're wrong. Okay. Okay, so Chip Gilkison from Cleveland Clinic lent me some of these cases, and I have to thank him for that. What do we see here? I'm sorry, Chip is from Case Western. How could I have said that? Okay, he's from Case Western. Okay, so what do we see here? There's the left anterior descending coronary artery. There's an aneurysm of the coronary artery. Very easy case. You get it right away. Aneurysm of the left anterior descending coronary artery. There are two major causes of coronary artery aneurysms. First one is atherosclerosis, like most other aneurysms, atherosclerosis. Worldwide, the most common cause is Kawasaki disease, but that's not that common in the US, and that's usually going to be seen in children. Kawasaki occurs in children, and if you see the aneurysm, it's probably a child. If you see a child with an aneurysm, it's Kawasaki. In an adult, it's atherosclerosis. Next, this was actually on a PE case, and the resident who was on made a beautiful diagnosis. This was unknown, that the patient had this diagnosis. There is the ascending aorta, descending aorta, PA, and left PA. PA, left PA, descending aorta. What do you think about that image? There is a huge patent ductus arteriosus, very easy to see on the CT scan. If you see the PA and the descending aorta connected, that's a PDA. How are these treated in adults? Typically, they are constricted. They're very small and constricted, so they can simply be coiled. However, this is gigantic, and she had to go to surgery. Okay. Now, this is one of those cases that you may very well see on the boards. They love to show these types of cases because it's one of the latest types of cases, and it's really practical, and it's used clinically. So what are we seeing here? That's the cine image. All you really need to know is cine or white blood. It's really called a steady state free precession image, SSFP. But if you say cine, that's fine. And what do we see? Look at the left ventricle. So is there any thinning? Yeah, there's marked wall thinning laterally. How about the contraction? Is it normal? Look at the marked hypocontraction. Actually, it's akinetic in the lateral segment. So what we want to know, is this viable or not? This is poorly functioning. So the physician needs to know, the cardiologist needs to know, does this patient need an angioplasty or CABG? So will angioplasty or CABG help that patient recover function? So we do the delayed enhancement study. So history is, study was done 7 to 10 minutes after, or 10 to 15 minutes after gadolinium injection. So what do we see here? Viable or not viable? Not viable. So this person should have medical management. They will not benefit from revascularization of this segment. Next. What do we see? So we see an MRA here in the left lung. Look at the normal branching pattern. In the right, the vessels are actually attenuated. And look at the central pulmonary artery. There's the main and left PA. There's the right PA. The right PA is small. The branching is attenuated, and look at this. There are actually two veins coming down here. These are the scimitar veins in the scimitar syndrome. There are actually two veins in this particular individual. We see the scimitar vein here coming into the inferior vena cava, and that's the typical location of drainage into the inferior vena cava. Okay, so scimitar syndrome. Is scimitar syndrome a type of partial anomalous pulmonary venous connection? Yes, because that pulmonary vein drains into the systemic circulation, into the IVC. That's essentially a right-sided, right heart drainage. Okay, how about this? This is a weird oblique image. What do you think? If you see a weird oblique and there's a coronary artery on the image, you're looking for one of two things, either a coronary anomaly or less likely a stenosis. So there's an anomalous coronary artery passing between the aorta and the pulmonary outflow tract. This is a coronary anomaly of the malignant type. So that's it. So how about this? This was actually a 19-year-old who had an abnormal chest radiograph. Why did he have a chest radiograph? Because he had an upper respiratory infection, cough, fever, sputum, productive cough, rule out pneumonia. No pneumonia, but there was a mediastinal contour abnormality. This image came up first as the MR was being done, and I thought, oh, this is lymphoma. But what is it actually? There's no enhancement. This is a cyst. It happens to be a mediastinal cyst, probably a pericardial cyst, because it is adjacent to the pericardium. But it's cyst, benign, very easy case, pericardial cyst. How about this? We see a mass or something, abnormality around the heart, and there's the main pulmonary artery compressed. Is this a thrombus or a tumor? It's a tumor. It's enhancing. Well, you can't be absolutely sure, but it doesn't look like a thrombus in that it's not dark, or it's not a filling defect. Is this malignant or benign? It's probably malignant because it's infiltrative. You see how it's sort of infiltrating around? There's the pulmonary vein. It's just going all over the place. This was a lymphoma of the pericardium. Okay, diagnosis. History is pulmonary hypertension. So differential diagnosis for pulmonary hypertension in an adult. What is the cause? So as I mentioned yesterday, chronic lung disease, emphysema, or fibrosis. Chronic thromboembolism. Mitral valve disease. Left to right shunts. And primary pulmonary hypertension. So left to right shunts, most commonly in an adult who's not diagnosed, it's probably an ASD or partial anomalous pulmonary venous connection. This particular individual, what do we see? There's an ASD. A lot of times on CT, in a non-gated CT, there's blurring because the heart's beating, so it's hard to tell. But sometimes when you catch the image like this, beautifully caught in still motion, it is easy to tell it's an ASD. Okay, so what is this? The arrow helps you out a little bit, but this is a coronary CTA. There's the angiogram. Actually, the angio is harder to read, isn't it? But we can see the coronary CTA in different projections. What vessel is that? I think that's really important for you to know which vessel it is. It's the LAD. And how do I know that? Because there is the left main, that's the nubbin of the circumflex artery, and nubbin meaning that it came out, it got cut out during the reconstruction. There's the left anterior descending artery. This is extra credit. What vessel is that? The first big branch off the left anterior descending artery is called the first diagonal branch. This is distal to the first diagonal, and that is the right coronary artery. If you know all of that, I would give you a 72. If you just know that there's an LAD stenosis, 70. And if you think this is the brain, I would give you a 68. Okay. Next. So what do we see? So what do we see here? We see calcification. If you see calcification in the heart, You're thinking of just a few things. Okay, pericardial calcification, you probably are not going to get shown a coronary calcification on a plain film. That's a little bit tough, but pericardial, valvular, an aneurysm, or an aneurysm. Those are the most likely things that you'll be shown that have calcification. So this is pericardial calcification, and this is consistent with calcific pericarditis, often due to TB. Okay, constricted pericarditis has a number of causes, such as cardiac surgery or radiation therapy, but calcific pericarditis, if you see the calcification on a plain film, it's quite probable that it's TB, but it could be due to other causes of pericarditis. And this is also likely to be constricted pericarditis. Okay, so calcific pericarditis is a finding, but if you have pericardial constriction, which is a physiologic state, then it's called constrictive pericarditis. So they're not synonymous. Calcification doesn't mean constriction. Constriction is a clinical diagnosis. The calcification is the finding on the radiograph. But this is essentially, for board's purposes, calcific pericarditis, possibly TB, possibly uremic or viral pericarditis. Now, you can also see calcification of an aneurysm or pseudoaneurysm or a valve. If you cannot tell, if it's a cardiac case and you can't tell what's going on, look at the valve on the lateral view. Look at the lateral view and try to look for the aortic valve to see if there's a subtle calcification there. Because if it is, then that is aortic stenosis, calcific aortic stenosis. So if you're desperate to find an abnormality, look for that. Okay. What's this? Okay, so we see an MR showing marked thickening of the left ventricular myocardium. This is hypertrophic cardiomyopathy. This, I would call this symmetrical, concentric is the term that we use for hypertrophic cardiomyopathy. Most cases, 90% actually have asymmetric hypertrophy of the septum. So the septum is very thick, but the rest of the myocardium is not that thick. This is concentric hypertrophy. Could be hypertrophic cardiomyopathy, and that's what it is in this case. Concentric hypertrophic cardiomyopathy. Other causes, though, are systemic hypertension and aortic stenosis, valve stenosis. What's this? A mass. So it is adjacent to the heart or in the heart. Is this a thrombus or tumor? That's post-contrast. Does it enhance? Yes. Is this a tumor? Is it malignant or benign? It's extending outside of the heart. It's very large and extending out. It's probably invasive. This is a malignant tumor. Most malignant tumors are metastases, but this happens to be a primary tumor, a sarcoma. Please advance for me. Next case, a child, a 16-year-old boy. What do we see? Look at that plain film here. First of all, look how the aorta bulges out away from the spine. That is something that we're all used to seeing, the aorta bulging out. Because we look at images of 58-year-olds or 72-year-olds with hypertension and atherosclerosis. But in a 16-year-old, that aorta should be coming straight down. Instead, we see this figure 3 sign. Look at this. And we see that here again, the figure 3 sign. What else do we see? We see rib notching. So what's the diagnosis? Coarctation of the aorta on the plain film. This is how it looks on the MR. So you may see MRAs of this. You can see CTA. This is just a spin echo MR. And we see the coarctation. This is a discrete juxtaductal coarctation, the most common type. So coarctation of the aorta. Now, one thing is pseudocoarctation doesn't have a pressure gradient, whereas coarctation does. That's one thing that you need to keep straight in your mind. Pseudocoarctation seems like it's kinked, but it's not functionally significant. It's not the same as a coarct. What's this? Bulging out of the apex, calcification. It's a left ventricular aneurysm with calcification. It's a true aneurysm most likely simply because it's anteroapical. And true aneurysms have wide ostia. False aneurysms have narrow ostia. One other thing I do want to mention is you can see calcification in the LV in the absence of an aneurysm. Why? If you have a prior infarct, that can calcify. So an infarct can calcify even if there's no aneurysm. Don't call it an aneurysm unless it's bulging. How about this particular case in a child? Pericardium is markedly thickened. You can see the 2 layers of fat, the pericardial, sorry, can we go back please? Pericardial fat and the epicardial fat. There's marked thickening of the pericardium in a child. He actually had ASD repair, so he's had cardiac surgery. Diagnosis? It's probably constricted pericarditis. Again, constricted pericarditis is a clinical diagnosis. We need to get some clinical information, such as constrictive restrictive physiology, poor filling of the RV, poor filling of the right atrium and right ventricle, lower extremity edema, dyspnea on exertion. Those are all symptoms that suggest, signs and symptoms that suggest constricted pericarditis. And with UC thickening, that is consistent with pericardial constriction. How about this? Another mass. I think we're getting tired of masses. I don't know why I put so many in here. Okay. But does it enhance? Yes. There's heterogeneous enhancement. So tumors can be homogeneous or heterogeneous in their enhancement. They don't have to be they don't have to be homogeneous. This is heterogeneous. Is it malignant or benign? You can't tell by the enhancement pattern. You simply tell by other features. For example, involving 2 chambers. This is malignant. It's irregularly marginated and infiltrative, malignant. So this is malignant, it's a lymphoma. Okay, so CT scan, what are we seeing here? There's a filling defect right there. What is that? That is the left atrial appendage. It's very important to know that, to remember that. What's the underlying cause? It's one of 2 causes, atrial fibrillation or mitral stenosis. Now, mitral stenosis typically is going to give you a very large left atrium. This left atrium is not that big. So what do you think is the underlying cause? It's atrial fibrillation. Mitral stenosis should give you a big left atrium and big left atrial appendage. So there. Now you may have been looking at the coronaries. I think this is not a dedicated CTA, it's an awful quality study for the coronaries. Easy diagnosis, pericardial effusion. Next. So another mass, but this one is calcified. Remember I told you the most likely calcifications are valvular, pericardial, or aneurysm. But this is none of those. This is actually a mass in the pericardium, and it happens to be a calcified thrombus. So thrombus, calcified hematoma in the pericardium. So hematomas can also calcify. It's not common to see that on a plain film, though. Let's go on. So plain film here, nice example if I do say so myself. So what do we see? So big heart or small heart? It's a big heart. What else do we see? One of the signposts is left atrial appendage, left atrial enlargement. Does this person have left atrial enlargement? I think it's quite evident. You can see, first of all, this carina is splayed. It's more than 90 degrees. That left mainstem bronchus is elevated. There is a double density sign right there. That's the left atrium. And there's bulging out of the left heart border. That's left atrial appendage enlargement. And on the lateral view, you see posterior displacement of that left mainstem bronchus. Clearly, there is left atrial enlargement here. And one other sign that you can see during a barium swallow, these old-fashioned images, is compression of the barium column. They still have those on the boards, although there's some bias against showing them because we don't want to seem too fossilized. Okay, so what was this? This is left atrial appendage enlargement, left atrial enlargement and big heart. So this is mitral regurgitation. That's because it's a volume phenomenon causing enlargement of the heart. If the heart is normal in size, diagnosis is mitral stenosis. But this is mitral regurg. All you really have to say is mitral valve disease and you get a 70. If you say mitral regurg or stenosis, it's better. Well, if you get the right answer, it's better. Okay, so this is a pretty easy case. I showed you an example earlier this evening. So what do we see? A round or oval structure to the left side of the aorta. So it's one of two things, partial anomalous pulmonary venous connection or persistent left SVC. There. Is it branching in the hilum? Are there branches coming into it? No. So this is a persistent left SVC draining into the coronary sinus. Very easy case. You'll definitely get it if you see it. How about this? This is characteristic bulging out in this area. It's most likely one particular thing, but there's a differential. Most likely an aneurysm of the left ventricle. And because it's anteroapical, it's a true aneurysm. False aneurysms are postdiaphragmatic. This is anteroapical, a true aneurysm. Differential diagnosis, pericardial cyst or pericardial mass, a tumor, but it's almost certainly LV aneurysm. This is how it looks on the MR. So there's the normal image right there, short axis showing the left ventricle, concentric normal myocardium. How about here, a few images down? There's thinning and bulging. Wide ostium, wide meaning greater than 50% of the diameter of the aneurysm. So what is this? True aneurysm. So what's the cause? True or false aneurysm, the cause is a transmural myocardial infarction. This was a 17-year-old. Why did he have an MI? There are different causes, of course. And I haven't shown this case in quite a while to the residents, to my residents, but in the past they used to say, living in San Francisco, they used to say cocaine use. Well, actually, another little story. In San Francisco, we never like to say drug abuse, like IV drug abuse. Well, I always used to say IVDA when I was a medical student and resident. Once I came here, I heard the term IVDU, and I said, what does that mean? And I was told it's IV drug user because we don't like to be judgmental here. So anyway, cocaine use or abuse, as the case may be. Other causes are what? Hypertriglyceridemia, hyperlipidemia, or perhaps anomalous coronary vessels, if there are certain types, such as a vessel coming off of the left or coming off the pulmonary artery. But this is none of those. This was a trauma case. This patient was sledding in Lake Tahoe, and the sled went into the street and a pickup truck ran over his chest. So the coronary arteries were sheared and he had a myocardial infarction. But he's actually doing reasonably well now. Okay. How about this? We actually see fat here. You see this dumbbell shape here? There are actually two diagnoses here which we usually don't like to show on the boards, but if you see a dumbbell shape with fat in the atrial septum, that is only one thing. That is lipomatous hypertrophy of the interatrial septum. It's very important to know this. It suppresses out with fat suppression. Very important to know why, because typically it doesn't have much clinical significance. But on echocardiography, sometimes it looks like a mass in the right atrium. And they will send the patient to MR to assess, is this an actual mass? All you have to do is say, this is lipomatous hypertrophy of the interatrial septum, and you've cleared the patient. Do not recommend surgery here, please. The other thing that this person has is that little fatty area there, and that happens to be a lipoma, which is in addition to the lipomatous hypertrophy. Lipomas are benign, and they don't typically need surgery. So that is the lipoma, that's the lipomatous hypertrophy. Typically has a dumbbell shape because the fossa ovalis, where the foramen ovale was, that fossa ovalis doesn't have fat there. But there's marked thickening. So again, it's benign. Sometimes these patients have arrhythmia, but typically no symptoms. Sometimes arrhythmia, benign. Okay. What are we seeing here? MR, At the level of the arch, this is a spin echo image, T1 weighted. This is with gadolinium and fat suppressed. What do we see? Thickening of the wall. Look at the thickening of the wall of the innominate artery. And we see enhancement. This is characteristic of one disease. There's a differential, but everything else is extremely unusual. When I see this, I would say it's one disease. This is Takayasu arteritis. Why is there no stenosis? Remember, I showed you another case with stenosis in the arch vessels. This patient was only about 11 years old. So it's a young patient. It's not atherosclerosis, but Takayasu arteritis. Why? Because there's thickening and enhancement of the wall of the vessel. You can see this in the arch vessels. You can see it in the aorta. And this is the active inflammatory phase. And these patients, once they're diagnosed in this phase, they can be treated with steroids, and this is potentially reversible, or at least you can somewhat control it or help limit the extent of it. So if this person's treated with steroids, that's good. You can perhaps limit the extent of damage. The later phase where there's stenosis, it's too late. You can't do anything about it other than perhaps bypass. You can't treat with steroids. So this is the active inflammatory phase of Takayasu. Look for thickening and enhancement of the vessel wall. Next case. This is an Aunt Minnie. It's a little bit difficult case. You may or may not get shown it. I know someone who was very hard-nosed about cardiac plain films, and he said, this case is too difficult to put on the board exam. But if you get it, bulging out here. Well, first of all, mediastinum is centrally located. The heart is deviated to the left. That itself should tell you the diagnosis, but there's bulging out of the left atrial appendage, and in the AP window, the lung comes in there. So this is absence of the pericardium. We see that here again, lung coming in between the aorta and pulmonary artery. This is one of my most beautiful images. But I'm joking there, but we can see. The quality is not that good, but we don't see this very often, so I do want to show this image to you. Aorta, pulmonary artery, and the lung is coming in. That's characteristic, absence of the pericardium. Next, arrhythmia. You should get this case in an instant. Once you hear that history, arrhythmia or tachycardia, look for the myocardial signal. If it's high signal, it's right ventricular dysplasia. And please don't say, as one person once said to me, it's that thing in the right ventricle, but I can't remember the name. Okay. Anyway, so this is another patient, and what do we see here? Pericardial thickening. This could be constricted pericarditis. So with that history of dyspnea on exertion or lower extremity edema, and pericardial thickening of 4 millimeters or greater on MR or CT, we think constrictive pericarditis. Next, this is another use of the jet. Okay, so these jets I told you about, and what do we see here first? So, right ventricle, right atrium, left atrium. There's a VSD. What do you think about that jet? So it's passing from this side into the right ventricle. How do I know that? Because it's essentially there. It's beyond that septal defect. So it went across the septal defect. What does that imply? That means there's a left to right shunt because it's going from the left into the right. Okay, so be aware of jets. Jets are not only used for valves, they can also be used across septal defects. So if you see a jet like that, it may not be this obvious, but if you see jets, try to look for valvular disease or septal defects. Okay, this was actually a 4-day-old baby, but surprisingly, he has hypertrophy. He has thickening of the wall, of the septal wall. Diagnosis? Asymmetric thickening of the septal wall. Can only be one thing in a child. This is hypertrophic cardiomyopathy. 90% have this asymmetric thickening. Does everyone see that? That's the wall. This is the blood pool. It's bright blood. There's the wall. There's the normal wall. asymmetric septal hypertrophy. How about this? This is actually a pretty unusual case, and I'm just throwing it in there to wake you up. So on the frontal view, we actually see an air fluid level here in the pericardium. So there's hydropneumopericardium. Look at that air fluid level. What can cause this? The most common cause is iatrogenic. There's been instrumentation of a pericardial effusion, such as pericardiocentesis or drainage. But this is not the cause in this particular individual. Again, you can see that there, the hydropneumopericardium. Look at that, by the way. What is that? That's the esophagus. The person had esophageal carcinoma that invaded into the pericardium and caused this hydropneumopericardium. This is a very unusual case. You'll never get shown something like this. But remember, masses in or around the heart, the most common tumor is secondary. It's either a hematologous metastasis or direct extension. Okay, a cyanotic baby. So, cyanosis, you need to know, is this decreased vascularity or increased? Why? Because decreased vascularity, it's probably tetralogy of Fallot with a normal heart. With a big heart, it's probably Epstein anomaly. With increased vascularity, there's a huge list, but really the only things you really need to know are transposition of the great arteries. If you see a right arch, you think truncus arteriosus. If you see a big mediastinum, a big superior mediastinum, that's the snowman heart of total anomalous pulmonary venous connection. If you just say those three things, I would give you a 72. That is better than anyone else is ever going to do. So if you see a cyanotic baby, so if you see increased vascularity and they don't tell you cyanosis or not, you need to ask. You say, this person has increased vascularity. Are they cyanotic or not? Why? Because increased vascularity, cyanosis implies admixture lesion. Non-cyanosis implies a left to right shunt. So you go down two different paths. Left to right shunt is VSD, ASD, partial anomalous pulmonary venous connection, and PDA. Cyanosis is an admixture lesion, which is transposition of the great arteries. If there's a right arch, truncus arteriosus. If there's a big superior mediastinum, that's the snowman heart of total anomalous pulmonary venous connection. If I saw this, I don't see a right arch, I don't see a big superior mediastinum, I give the differential in a cyanotic baby, increased vascularity, I say this is an admixture lesion. Differential diagnosis includes transposition of the great arteries, truncus arteriosus, and total anomalous pulmonary venous connection. I would give myself a 72. Okay. And this is what the CT looks like. Look at the PA anterior to the aorta. The aorta anterior to the pulmonary artery. So if the aorta is anterior to the pulmonary artery, that's transposition of the great arteries. That's all you need to know. And let's come down. There's the aorta coming into that ventricle. That's the right ventricle. And there is the pulmonary artery coming into the left ventricle. So right and left ventricles. Right and left ventricles. That's it. This person actually had an old-fashioned type surgery, but we don't have to discuss that for our purposes here. What's this? Enlargement of the central pulmonary arteries consistent with pulmonary arterial hypertension. Possible etiologies include chronic lung disease such as emphysema or fibrosis, although I don't see that on this particular image. Chronic thromboembolism, mitral valve disease such as mitral stenosis, shunt such as ASD or VSD, or if this is a younger woman, primary pulmonary hypertension. That's it. Perfect. Thank you. Good job. Okay. How about this particular case? So we see an MR. If you ever see coronary arteries on a CT or MR, look for, in case you didn't hear me the first time, look for coronary artery anomalies. And I repeat some of these things over and over, not because I'm a parent and I'm repetitive, but because these are the things that people love to show on the boards. Okay, and we see here, there is an anomalous vessel passing posterior to the aorta. Actually, the circumflex artery is posterior to the aorta. So, and you can see that right there actually very nicely posterior to the aorta. And that is an anomalous vessel, retroaortic. This is benign, no surgery. Next. Okay. So do we need, this was done 10 minutes after gadolinium enhancement. So viable or not viable? Look at the myocardium. And if it's not viable, it's not going to be subtle. This is normal. Well, I shouldn't say normal. This is not delayed enhancement. Okay, so this is viable. There's no enhancement of the myocardium. You see high signal here, but that's not the myocardium. That's a little bit of fat out there. But we see no enhancement. This is viable. And the patient, if they do have a functional deficit in the heart, they can go on to have revascularization and they can benefit. So angioplasty or surgery, viable. Last few images, non-viable. This person cannot benefit to improve this, or at least these segments cannot benefit with revascularization. Does everyone see that? It's clear, very clear to me at least. And I hope it's clear to you after this. This case is actually perforation by these pacemaker leads, and there was hemopericardium. How about this? There's a mass there, high intensity, post-operative. This is hematoma, seroma. Those are the most likely possibilities. This turned out to be a hematoma, post-op hematoma. Pretty straightforward. Okay. How about this particular case there? There's a vessel right there. Isn't that interesting? That's a pulmonary vein and it's draining where? IVC diagnosis. Scimitar syndrome. These are just simple axial images. Very easy. Next case. Okay, how about this? Right aortic arch. Retroaortic. Is this a vascular ring? Yes. Right arch with retroaortic or aberrant subclavian artery is a vascular ring. This is not mirror image. Mirror image is associated with congenital heart disease very strongly. This is also associated with congenital heart disease, but not very strongly. It's primarily important to know because it's a vascular ring. And look at that trachea, how compressed it is. It's a vascular ring. On the lateral view, there's the aberrant subclavian artery, and the trachea is markedly compressed on the sagittal view. So a couple more images here. We see a mass there. It enhances. We know it's a tumor. This turns out to be a myxoma. Myxomas are usually LV, but it was in the RV. And we see that right there. Okay, the last two cases are very unusual. This is one of the cases that Dr. Higgins said you would never get shown on the boards, and I doubt it myself that you would ever get shown, but just for fun, what could this be? We see this barrel, like a double barrel of a gun. Okay, now don't have that impression that I'm going to shoot you, but you can see the double barrel of the gun. That means that both vessels are coming out of the right ventricle because there's muscle around the bases of both vessels. And if there's a muscular infundibulum at the base of the vessel, that means it's coming out of the right ventricle. That's just by definition. So two vessels coming out of the right ventricle, double outlet right ventricle with a huge VSD and a common atrium. And how about this? Again, I doubt you'll get shown this, but just for fun, after all this, we deserve a little bit of a reward. And we see a very small right ventricle with a VSD. So there's a small right ventricle, hypoplastic with a VSD. But the connection between the right atrium and right ventricle seems to have a band of muscle and fat. So there's tricuspid atresia. And that's one of the reasons why we love MR, especially for congenital heart disease and even for ischemic disease, because you can see everything so clearly. If you've ever seen an angio, how many of you have seen cine angiograms in pediatric patients? Well, just one or two, but if you ever see those, I don't understand how anyone can make diagnoses off of those. This is very easy, tricuspid atresia.
I'm going to spend the next 30 minutes or so trying to cover at least some of the basics of pediatric neuroradiology. I'm sure all of you realize that pediatric neuroradiology is a pretty extensive subject, so I don't expect to cover all of it. But hopefully I can show you some of the basics, and it'll make it easy for you to at least have a good approach to these types of images. I'm going to show you the unknowns first for about a minute or so. Okay, and I'll cover those cases throughout the talk, so you guys will have the answers to those by the end of the talk. So I just want to talk about, in general, how you should approach pediatric film. Typically we do MR, but we also do some CTs for certain indications, although we realize the risk of CT being that of radiation to the developing brain, so we prefer to do MR. But whenever you look at an MR of a pediatric brain, you should have a certain approach that you take to the film, just like you do when you evaluate a chest X-ray. And it's important to look at the midline structures on your images, and typically those are seen on the T1 weighted images, because typically sagittal T1 weighted images are obtained. And it's important on the midline image to look at the corpus callosum. That will give you an indication of the patient's overall brain volume, in particular white matter volume. It may also give you an indication of whether or not there are some developmental malformations in the brain. And then there are other structures that you can see on the midline image that are very insightful also when you evaluate the pediatric brain. You can look at the fourth ventricle, and that's a common location obviously for pediatric brain tumors such as medulloblastomas and ependymomas. Also look at the pineal region, which is also a common location for tumors such as germ cell tumors. And the suprasellar hypothalamic region, again, another common location for tumors including craniopharyngiomas, as well as astrocytomas. And in a young patient, if you see a hypothalamic astrocytoma, you need to think about neurofibromatosis type 1. Also, you should look at the white matter. You should evaluate it on both the T1 and the T2 weighted images, both for overall volume, as well as looking at the myelination of the white matter. And we'll briefly discuss and show some examples of normal myelination. Then you should go out and look at the cortex, look at the overall thickness of the cortex, as well as the overall sulcation pattern. And then lastly, don't forget the deep gray nuclei. They can be involved in many different disorders, including hypoxic ischemic injury, including metabolic disorders, just to name a few. And lastly, I want to mention that the pediatric brain is very interesting and, of course, very challenging because it is very dynamic. And so it's important when you evaluate a pediatric image to know the age of the patient, because the myelination will continue to proceed over the first 2 years of life, the sulcation will continue to proceed, and so in order to identify something as an abnormality, you need to know what the child's correct age is. So just a few words about myelination. A couple of basic things. Some myelination does begin before birth, but usually at the time of birth at term, typically you see myelination in the posterior fossa and the brainstem and in the posterior limb of the internal capsule. So a lot of myelination actually obviously occurs after birth during the first 2 years of life. And in general, it progresses from a caudal to cephalad direction. and from a dorsal to ventral direction. And typically, for instance, the pathways that you would think would be important for a baby to use in terms of functioning, like the motor and sensory pathways, those typically get myelinated before the pathways involved in higher cognitive functions are myelinated. And that just makes sense from an evolutionary standpoint. And if you can't remember the exact milestones of myelination, you can always say when you are taking a case that you think that this myelination is delayed for the patient's age, but you would go look in a textbook such as Dr. Barkovich's book on pediatric neuroimaging to confirm what the expected myelination would be for a patient of the age that they tell you. And in terms of the changes that myelination has on the images that you look at, I'll show you some examples of immature brain. But the changes that you see on the T1 weighted images typically precede those that you see on the T2 weighted images. And we'll just go over some examples of that. So for instance, here's a premature infant. Okay. A 28-week premature infant, and there's an axial T2 weighted image and an axial T1 weighted image. And you can see that the white matter is bright on the T2 weighted image and the cortex is dark. And this is the opposite of what you're used to seeing, because typically you look at a mature myelinated brain like in an adult, where the white matter is dark relative to the cortex. And on the T1 weighted image, you can see that in this case the unmyelinated white matter is dark relative to the cortex. Again, the opposite of what you usually see in an adult brain, which you presumably have seen more images of, where the white matter is typically bright relative to the cortex. Let me also just mention that sulcation also continues to proceed with development. You'll notice that the brain is fairly smooth, and there are very few sulci. You can see the sylvian fissures, some of the frontal sulci, but very little. And not only are there fewer sulci, but they're also more shallow. And as the brain continues to develop, more and more sulci will develop, and the sulci that are there will become deeper and more complex. Here's a 34-week infant, T2 weighted images. You can see that in terms of myelination, it looks fairly similar. The white matter is still bright relative to the cortex. That's normal. But now you can see that there are many, many more infoldings that have developed along the surface of the brain, and this is just a normal progression of sulcation. And here's a term newborn, which even compared to that 35-weeker, so even in the course of 5 weeks, look at how the sulci have become more deep, right? And there are more numerous sulci. And now we start to see myelination in the posterior limb of the internal capsule, which on the T1 weighted images is bright. We talked about how the myelination changes the white matter on T1 from dark to bright. And on T2, the myelination is evident in the posterior limb of the internal capsule. In the region of the cortical spinal tracts is this area of low T2 signal. And you should see this in a term newborn. Also, the corpus callosum on a midline sagittal image, you can see in a term newborn, you'll notice that it looks different from the adult corpus callosum. It's not as thick. That's because it's not myelinated yet. And it's also uniform in thickness. It doesn't have the normal bulbous appearance that you typically see in the splenium or in the genu. And so here's just an example of progression of myelination in a 6-month-old infant, where much of the white matter is myelinated on the T1 weighted image. You have some myelin in your genu of your corpus callosum and in your splenium of your corpus callosum. And look at the corpus callosum, how it looks different from that newborn image. The callosum looks much thicker. The genu has this bulbous appearance, and the splenium has this bulbous appearance as well. And that's normal. And most of the changes that you see on the T1 weighted images during myelination, you'll see in the first 8 to 10 months of life. And after that, you'll see much more visible changes on the T2 weighted image. So here's that same 6-month-old infant on T2 weighted image, showing you really that there still is not much myelination on the T2 weighted image. But compared to that newborn, where there was just a small amount of myelin on the T2 weighted image in the posterior limb of the internal capsule, there now is much more prominent myelination in the posterior limb of the internal capsule, also seen here. And you can also start to see some myelination, primarily in the splenium of the corpus callosum, with a little bit beginning in the genu. And again, the myelination lags behind on the T2 weighted image compared to the T1 weighted image. By about 10 months to a year, the myelination should be completely normal appearance, like an adult brain, on the T1 weighted image. And this is an example of a 14-month-old child, and you can see that all the white matter is myelinated. And you can see that now on the T2 weighted image, I showed you previously the 6-month-old infant, which didn't have that much myelin on the T2 weighted image. But after about 10 months or so, you start to see much more myelin on the T2 weighted image, and this is a 14-month-old child, where a lot of the deep white matter is myelinated. You can now see complete myelination of the genu of the callosum. Even the anterior limbs of the internal capsules are fully myelinated. And by about 2 years, the white matter should pretty much be completely myelinated on the T2 weighted image. Even the anterior inferior frontal white matter, which is one of the later areas to myelinate, as is the anterior temporal lobe white matter. And there you'll always notice this area of persistent high T2 signal, which represents the terminal zones. That's a late area of myelination, and that can have this appearance until around 10 years of age. And it's important when you see this abnormality that you evaluated on when you see this finding rather, that you evaluated on the first echo images of the T2 weighted images, and it should not be very bright on those images in order for it to represent normal terminal zones, and you should not see any associated volume loss in the parenchyma. And that's typically around the trigones of the lateral ventricles.